Now I'm going to cover the stabilizing muscles. There's a specific group of small little muscles called the rotator cuff that form the rotator cuff, and their primary function is to keep that humeral head spot on the glenoid, no matter where your shoulder or your arm is. A common mnemonic for remembering this is SITS. Each of these letters forms the first letter of each of those four muscles. Top one is called the supraspinatus. As its name implies, it's above the spine. That's where its origin is. And it inserts onto the top, so the superior facet of the greater tuberosity. If you were to bring origin and insertion closer together by way of contracting that muscle, it abducts the joint. And this is shared with another muscle, which is the major mover of the arm, called the deltoid. So it turns out that the first 35 to 45 degrees is pure supraspinatus. So, greater from 0 to 35, let's say, degrees, it's pure supraspinatus. And then, once it gets greater, then it's the deltoid as well. So if you want to isolate the supraspinatus muscle, you would have to begin with the arm about 30 degrees away from the body, and I'll demonstrate that in a moment. The infraspinatus as its name implies, originates below the spine of the scapula, and we don't separate it functionally from the next muscle called the teres minor because they're so close together. So this is the origin of the teres minor muscle. So infraspinatus connects to what we call the middle facet of the greater tuberosity, which is a little on the backside, as well as teres minor. So when they contract, they don't elevate the arm, they cause it to externally rotate. And that's exactly what you do when you try to test its motion. So we'll just put external rotation. Supraspinatus, I'm sorry, should be abduction. And finally, we have our fourth muscle, and we'll need to have an anterior view of the anatomy in order to appreciate its location. So I'm going to just start with the humeral head. We're going to put the glenoid here. We're going to create that lesser and greater tuberosity. We're going to put the acromion here and a clavicle here, and the manubrium of the sternum over here, and then we have coracoid process, and finally the scapula. So subscapularis, under the scapula, its origin occupies a great part of the surface of the anterior part of the scapula, and it inserts into the lesser tuberosity. So when these contract, it causes your humerus to internally rotate. Now, right along with it is our big mover of the arm into internal rotation, which is a pectoralis major muscle. To lessen the input of the pec major in internal rotation, If you put the arm behind the person's back and have them lift off, they're using less pec major and more subscapularis. So that may help point toward the subscap and actually give you a more pure test of its strength. I'm going to put the lift-off test here as a reminder. We're going to go ahead and demonstrate these tests for you. So I'm going to have you stand here facing me at an angle perfect. Supraspinatus. I'm going to have her at 30 degrees, abduction. Do not let me bring your arms in. So you can see she has obvious weakness of her left supraspinatus. Okay, let's go ahead and keep the elbows pinned in. And I'm going to try to push. This is neutral. You need to have the arms facing straight out, not out here and not in here. Okay, I'm going to have you resist my attempt to push your hands in. Very good. And then we'll move right to subscapularis and push in. And be careful again to make sure the patient is in neutral. So the start point is there. There we go. Let's have you turn around. We'll do the lift-off test. One hand at a time. There's really no standardized distance or amount of pressure. It's a comparative test. So, very good. Let's do the opposite side. Lift off, push right into my palm. There we go. There we go. Thank you.
And if they can't bring their hand behind their back, is there another way to do that test?
Alternatively, in fact, many times, those who have a subscapularis tendinopathy cannot put their hands behind. So, alternatively, they can put their hand on their abdomen and press in, and you try to pull the wrist away right into their internal rotation. So that covers our rotator cuff muscles individually. As a group, there is a test, and I would like to bring it over here. The question is there a sulcus sign? A sulcus is what results when the humerus cannot be stably maintained. And so it points to a rotator cuff tear. A sulcus sign. So we're really checking the integrity of the rotator cuff as a mechanism. What you do is you position the thumb so it's touching the lateral part of the acromion and the top of the greater tuberosity. This is a giant thumb, but it'll do. There's your little wrinkles. Okay. And while you're monitoring here, you apply inferiorly directed traction with your other hand this way. So if this separates, the rotator cuff has some kind of a tear. This separation right here is called the sulcus. Let's see. So I'm going to just show you where the lateral border of the acromion is, right there. And this is the top of the humerus. So I'm going to put this thumb here for monitoring. Most effectively is for you to lean in, so putting the web space between the thumb and index finger at the crook of her elbow. And by pushing down, these separate, see? if you look closely, everybody has some, not laxity, but resilience. Can you see that kind of flatten and curve? That's kind of a sulcus, but not really. So that's where you monitor the strength of the rotator cuff mechanism in this test. Thank you. Okay, so that covers the rotator cuff muscles. I think we should add one more muscle. And so we introduced the long head of the biceps when we discussed our slap defect. There's our bicep muscle. There's that long head going up the bicipital groove. Right where it makes that turn is a point for injury. Then it continues and it attaches to the superior glenoid labrum up here. Okay? So I'm going to mark that. That's where you can create bicipital tendinitis. So let's go ahead and put that entity on the board. So 2 trouble spots with the long head of the bicep. Right here at the superior part of the bicipital groove where it makes its right angle to go into the joint capsule, and the other trouble spot is where it's attached at the superior glenoid. It's good to be able to localize where this is, and to do that you use your landmark of the acromion. If you find the lateral edge and the anterior edge, and some people can feel that corner, if you locate that and you have the patient in anatomic position, you go down about 3/4 of an inch, more or less. You can put your thumb right over that point, internally and externally rotate the arm, and you'll feel the prominence of the lesser and the greater tuberosity under your thumb. And so the flat area in between is exactly where that bicep tendon is. Switch arms. Yeah. So this is the lateral edge of her acromion. There's the anterior edge. This is that corner. I'm going to put her in anatomic position, just palm up, arm at the side. Good. Go down about 3/4 of an inch. So I'm going to put my thumb here and I externally rotate. You can feel immediately her lesser and her greater tuberosity rolling under the thumb, and that is exactly where the bicep tendon is. So when you do the tests for bicipital tendinitis, you know exactly where that pain is localized. So now we can just stay there, because I'm going to go ahead and introduce the speed test. So it's going to be resisted, of course, with the straight arm. Resisted pressure at 45 degrees of flexion. So we'll go ahead and do that. Straight arm, 45 degrees of flexion. That's where she's going to hurt.
Ow.
Positive for bicipital tendinitis. But the question was, where did that hurt? Is that where your pain was?
No, it was here. No, I'm kidding. Yes, it was there.
Good. Thank you. Oh, we got one more. These are both provocative tests. The second test is called Jurgensen. I kind of summarize this test as just resisting supination. If you have someone who works out at the gym and knows what a bicep curl is, that's the movement you want them to do. But if you have an older patient or somebody who's not familiar with that, I'm sorry, I don't mean to imply that older people don't. But if someone's not familiar with that, you can give them the instruction, starting with the elbow bent, palm down. You hold their forearm. I want you to bring your palm to your chin. And that reproduces that motion. So by resisting, go ahead, just maintain that right there. She's contracting her bicep. That's going to create tension at this site. And sometimes if you have a strain of the transverse humeral ligament, the bicep tendon will actually snap out and pop. Thank you. Okay. Just FYI, the short head of the bicep attaches to the coracoid process. Good. That covers pretty much the muscles, the stabilizing muscles of the rotator cuff.